So ERN Skin is 56 reference centers in 18 European countries. We are 12 people. We cover 10 different diseases, and we are from 8 countries. You have the details on the slide. I'm going a bit quickly. The patient satisfaction questionnaire was needed to measure the impact of ERN Skin centers to improve the quality of care and their performances. And EPAG advocates have been not only main contributors, but really developers of this questionnaire. So to begin with is there are 18 ERN indicators to capture added value. So how much our level of empowerment, our contribution and satisfaction is needed for the purpose to measure exactly the satisfaction that is needed as an integrated process of monitoring ERNs. So our ERN Skin coordinator asked us during an EXCOM meeting to prepare a questionnaire to measure really the level of patient satisfaction after they've had a consultation in an ERN Skin center. So we started, maybe I can share one thing. Okay, I cannot share. Well,
Marie-Claude, wait, I will stop sharing, and you can try.
I will just share. Okay. Okay. So this is the very, very first draft we had. That was something not easy to read, not easy to answer, and way too long, as it had 4 pages. So after our work, okay, I will stop sharing. Okay. We ended with something that was much more easy to use and went up to an A4 one-side page that has this kind of shape. So how did we go through from the very first draft and now what we have? Today the questionnaire, you can go back to the slides, I know. Yeah, we have 26 items and we divided it in 4 main sections. The first section is just general information on the patient and which center he consulted in and so on. Then 19 questions are about the consultation itself and the follow-up. Then we have 5 questions on treatment and therapeutic research, and then only 2 questions on the global satisfaction that mostly are about the general environment of the consultation, the places and accessibility and so on. And then we left a short blank section for any more comments it's needed. We hope it covers all patients' needs in terms of satisfaction. And we first developed it in English, and then we translated in our mother languages. We have now 6 different versions because we already have added Italian to the one that are listed. We really hope it has the potential to improve patients' care, because after being studied, this questionnaire the answers, the results should be given to healthcare and centers for them to improve what they are doing. Sorry, I missed, excuse me, phone calls. As well as improving patients' care, internally, among all the RN skin centers, it will be used to manage the performances and to identify the areas of improvements. And coming from patients' experience and needs will give, we hope, the most added value. And last but not least, these results will be part of the evaluation process that takes place every 5 years for each ERN center. The biggest challenge we had was to find a common terminology to represent all patients' needs, different skin disorders, and treatments. And even the word of treatment, we have here today Ingrid that kept saying epidermolysis bullosa doesn't have a real treatment. Can we use the word treatment? That was a main point, to find really the good terms to really address all patients' needs and be really understandable. So next slide, please. Yeah. So among the skin impact groups, we were 8, covering 8 different disorders that started from the very beginning asked by our coordinator. It has been really a fruitful exchange between patient and clinicians. We had the first feedback to clinicians who added some questions. For instance, in our questions, we were asking whether during the consultation, the patient had someone to support him and go with him through all multidisciplinary consultations. And when we gave the first feedback, clinician says, well, this kind of person doesn't exist in any hospital, so you can't ask the question. But this was a real both ways work with clinicians. And all our feedbacks were heard, and we heard also all the clinicians' feedbacks. Now, doing all this work showed how we can really contribute to ERN, how we can really add value, and what are the skin patients' needs? What is important for them to show in terms of satisfaction? And this was a really good collaboration between clinicians and us, of course. So how could we achieve that? First, as I said, a very good collaboration with ERN management, clinician, and us. We all wanted, really, we really had a strong willingness to share ideas, having all in mind that the main thing was the benefit for the patient, and also really considering the various disorders included in ERN skin. We all agreed that we needed a questionnaire that was short, easy to fill, easy to answer, and covering as much as we could the patient's needs. We were heard, and our work has really an impact now. Among our group, it was very important that we had a good communication, coordination, commitment, and each one of us used his own skills. Diana, who is here, is English mother tongue, so she always reviewed our funny translations. Someone else, Marjolaine, who is here too, had special skills on building a questionnaire and going back from the written thing to the grid thing was the main idea Marjolaine brought to the group, and I had the opportunity to follow Euralis leadership school, which was very helpful. So each one of us brought to the group his personal skill, his knowledge about a specific disorder, and patient's needs. So all together gave a really good group, really good working group. And what we learned during the process was only patients' views can really represent patients' needs. This is why we choose as much as possible to do translations ourselves from the English first first questionnaire, because even through the translation process, we still had discussions about what we really meant, what exactly was the question, what we wanted really to know. And for some words, in some languages, we had different translations. So that was a second step in the process. And we really thought that asking professional translators would not have done such a precise work. We found common needs for all skin patients. We had a common goal and a common perspective. We could work because the group had a coordinator that managed all the ways in and out with the clinicians and among us all. We had really to find the common words, despite the differences of the disorders, the countries, the backgrounds. And this is why I think we have a good questionnaire, because it really covers all the differences. As I said, it has been difficult to find the right translation in each language to be sure the question reflected exactly what was asked and understood in each country for each disorder. And above all that, showing the clinicians and all healthcare professionals in ER and skin, we could produce a qualitative work, and we have an expertise. And doing this with trust and mutual respect helped build really a good relationship with them. So now, next steps, we still are missing translations in other languages. So talking with the ER and skin coordinator, the idea now is to ask healthcare centers in the languages we are missing and see with them if they have patient groups or organization that could do it. Once again, not to ask professionals. It is now in the hands of symptomatic group coordinators for them to review and see if there is a need to add one or two specific questions for some disorders. Then it will be published on ERN Scheme website. It will be accessible online, but also handed over for those who don't have the internet. We thought we should maybe revise it within 2-3 years after having worked for some time, just to see if we need maybe to change some question because they seem not to have been really understood. And Jessie will explain the validation process. So we need now to discuss with the clinicians about this validation process. That is another, it doesn't mean that it is not valid to use it now, but it would be another step, and access to publications and so on. So thanks you very much.
Great, thank you. Thank you very much, Marie-Claude. A great example, I think. Note down your questions if you have any questions, and we continue with Jessie. And then after Jessie's presentation, we have half an hour of Q&A. So are you ready, Jessie? Yeah, okay.
Okay, I'm gonna share my screen. Can you all see my screen?
Yeah.
Perfect. So I will leave just this view, not in. I won't put my PowerPoint in full screen because I have prepared some additional slides in case you have any questions. So I'm going to go through my slides and present you the HCare pilot survey that we've been working on, well, that I've been working on since August 2019. And, but you will see that it has begun before. So this is the same starting point as the questionnaire that was presented by Marie-Claude, which is that ERNs have 18 core indicators for their continuous monitoring, and one of them is about patient experience and patient satisfaction, but it has not been defined yet because only a survey can allow to measure patient satisfaction. So we wanted to see, and then when I say we, it's me, it's your word, it's on 4 ERNs. I will come back to this later. We wanted to see if a common feedback mechanism could be created in order to measure the evolution of care experience. And I will let you read the slide, but basically just to feed the strategic decisions of ERNs and to allow to evaluate the care satisfaction of patients within their ERNs. So the objectives of the pilot survey, because what we've run within the last year is a pilot survey. So it's been initiated by 4 ERNs, Eurogen, ERCNet, Lung, and Gentris, and supported by the Wear Barometer Survey Initiative, which is the survey program of Eurodis, and I was coordinating it. So the aim is to test the implementation of a survey on a small scale, so on 4 ERNs, to see if a feedback mechanism would be sustainable and to see what are the limits that we could see or the challenges that we could encounter across to scale up and make a feedback mechanism across ERNs and across member states. to see how we could practically implement this on a large scale in terms of resources, time, and budget, and to also test the robustness of the survey, to agree on the dimensions to measure and the best questionnaire or tool to measure care experience, and to define the best means to get a sufficient number of respondents, which is not always very easy, as you will see. So what we did is that we first created, first a topic expert committee was created with ERN coordinators and clinicians, ERN managers and EPAG representatives from the 4 ERNs of the pilot. Then the topic expert committee defined and rated the dimensions of the survey that we should find in the survey. So here you can find them listed here. And then I was hired in August to run first a literature review to see if there were some existing scales. So I will come back on the fact that it's validated. If there are some existing validated scales that would allow to measure the different dimensions that were defined for rare and complex disease patients. So there was none that existed already. So we chose an existing scale that was made and validated for chronic care, and we adapted it. So we created the PAC-RD, the Patient Assessment of Care for Rare Diseases, and the Patient Assessment of Care for Chronic Diseases, and the caregivers, sorry, the Assessment of Care for Chronic Diseases, for Rare Diseases. We added some questions, and I will then show you the scale. We disseminated the survey from December to March online to all rare disease patients and caregivers. Anybody could answer as long as they were living with a rare disease. It was mostly through, it was an online survey, so it was through the Barometer platform. And also on site, we were, so 36 hospital units which are part of the 4 ERNs of the pilot were participating, and they were distributing posters and leaflets to patients and to caregivers to ask them to participate in the survey, so to go online and answer to the survey. And then we're still in the analysis of the results. So we were, when discussing before with Marie-Claude and with Anne-Laure and Lenia, I was asked many questions about validated skills. So I have other aspects of the survey that I can talk about, but maybe for my presentation I will talk more about the validation of a scale. So the idea of a validated scale is that it's a type of questionnaire. So what Marie-Claude and ERN's key and patient representatives developed is a questionnaire. It's not yet been validated because, so first, a scale, a validated scale, is a scale that has been developed to be administered among the intended respondents. So for instance, you saw that we took a questionnaire that was developed for chronic diseases, and we are using it for rare diseases. So there's already a difference there, is that we have to see if this questionnaire has the same specificities and is as valid for rare diseases as for chronic diseases. So the validation process should have been completed using a representative sample demonstrating adequate reliability and validity. I will also come back on that. And if no existing questionnaires are available or none that are determined to be appropriate, we should contrast a new questionnaire. So that's not what we did. We used an existing questionnaire and we adapted it. So what we know for sure is that the questionnaire that we have is not fully validated, but still it's a partial validation, but it's a good partial validation at this point. And if a questionnaire exists, but in a different language, the task is to translate and validate the questionnaire in a new language. So how do you validate a questionnaire? You have several steps. So this is one way to represent those steps. So first you develop items. Items are the individual questions that you find in the questionnaire. So you look at the domains, the dimensions that you want to measure. You create questions, items, and you may end up with, for instance, 50 items. Then you check the validity of the items, which means that this is what Marie-Claude and the orange skin patients have done. It's that they're just checking that you are sure that what people understand when they read the question is what you wanted them to understand. So usually there are what we call cognitive interviews with patients, and you ask them to answer the questionnaire and then to tell you how they understood the questions. Then, so this is also the pretesting of questions. And then you do the sampling and you administrate the survey, which is what we can call field work, or what I usually call survey dissemination. So you have just people entering the survey. And then based on the responses of people who took the survey, you run several statistical tests, which are all described here, or very briefly described here, to see which questions are the most correlated together, which ones covary, which ones are the most significant based on the answers that people gave. And you may have started with 50 questions, and then you choose maybe the 15 or 20 questions that are the most relevant for your questionnaire based on the statistical tests that are being run.